Physiology SAQ 11 briefly compare the placenta and lung with respect to their physiological role in gas exchange, 3 marks. The rate of gas diffusion during gas exchange in the placenta and lung follows Fick's law of diffusion. Gas exchange in the placenta is less efficient than in the lung due to several reasons. Minimum diffusion distance is larger in the placenta, 3.5 microns, than in the lung, 0.5 microns. Permeability of the blood-blood barrier in the placenta is lower than the permeability of the blood-gas barrier in the lung. Total surface area of the placenta is smaller than that of the lungs, 16 meters square for the placenta at term versus 60 meters square for adult lungs. The normal alveolar to arterial oxygen gradient is 5 to 10 mmHg, whereas it is 30 mmHg between the maternal sinuses and fetal capillaries of the placenta. Oxygen transfer is also decreased by low blood pressure in the uterine artery, for example due to aortal cable compression or maternal hypotension, and during uterine contractions. B. Highlight the peculiarities of oxygen delivery in the fetus, 7 marks. The fetus has to draw oxygen from the environment through the mother and via the placenta. Oxygen delivery to the fetus therefore takes a long and hazardous route. Hypoxia in the tissues of the fetus is a reality, but there are many compensatory mechanisms in place. This includes increased maternal blood supply to the placenta, increased maternal minute ventilation, increased fetal blood supply to the placenta, higher level of fetal hemoglobin, and HbF has a higher affinity for oxygen than maternal HbA. Increased maternal blood supply to the placenta. Uterine blood flow increases 20x during pregnancy and is enabled by increased cardiac output, 50% increase at term, which is caused by increased blood volume, increased preload, and progesterone-induced reduced SVR. Uterine blood flow at term is 500 to 750 mL per minute, and 85% of this goes to the placenta. This increases DO2 to the placenta and increases CO2 excretion from the fetus. Increased maternal minute ventilation by up to 50% at term reduces PCO2 and increases PO2 slightly in the maternal blood to increase the pressure gradients required for gas diffusion across the placenta. Progesterone sensitizes central chemoreceptors. Increased pressure gradients amplifies the double Bohr effect. Increased fetal blood supply to the placenta. Fetal cardiac output at term is about 1 liters per minute, and 25 to 55% of this goes to the placenta. A higher level of hemoglobin in the fetus enables better oxygen carriage. Hb at birth is 17 to 18 grams per deciliter. Fetal hypoxia stimulates erythropoiesis. Fetal HbF has a greater affinity for oxygen compared with maternal HbA. The P50 of HbF is 20 mmHg, and this is lower than that in adult HbA, which is 26.6 mmHg. This means that fetal Hb has a higher oxygen affinity, and this assists it to load oxygen in the placenta, while maternal Hb is unloading oxygen. HbF is a tetramer consisting of 2 alpha and 2 gamma subunits that has no beta chains, unlike HbA. Beta chains bind to 2,3-DPG to cause increased P50, which does not occur in HbF. The double Bohr effect improves the gradient for oxygen diffusion from the mother to the fetus. The Bohr effect is a situation where the affinity of hemoglobin to oxygen is reduced when pH decreases, for example due to high PCO2, and increases when pH increases. There is a right shift in the OHDC mechanism. Decreased pH or increased PCO2 increases Hb in the tense state, and this reduces its affinity for oxygen. Increased pH or decreased PCO2 causes Hb to be in the relaxed state, and this increases their affinity for oxygen. The double Bohr effect refers to the situation in the placenta where the Bohr effect is operative in both the maternal and fetal circulations. At the fetal circulation, umbilical artery has high PCO2 of 52 mmHg. At the placenta, CO2 diffuses across the maternal uterine artery down its concentration gradient to PCO2 of 32 mmHg. Reduction of PCO2 in fetal blood causes a left shift in fetal OHDC and increases oxygen affinity of Hb, facilitating oxygen transfer. Decreased PCO2 on the fetal side of the circulation assists in oxygen loading. In the maternal circulation, increased PCO2 of maternal blood from diffusion from placenta causes a right shift in maternal OHDC. This increases offloading of oxygen. Increased PCO2 in maternal intervillous sinuses assists oxygen unloading. The Bohr effect facilitates the reciprocal exchange of oxygen for carbon dioxide. The oxygen dissociation curves for maternal HbA and fetal HbF moves apart in opposite directions due to the double Bohr effect. The design of the fetal circulation favors better oxygen delivery to the brain and the heart. Oxygen-rich blood from the placenta passes through the umbilical vein directly to the fetal liver, where the circulation splits and flows into both the ductus venosus and portal sinus circulation. It then passes into the IVC and enters the right atrium. Blood flowing in from the ductus venosus into the IVC is primarily diverted by the eustachian valve towards the foramen ovale and into the left atrium, and then to the left ventricle, and empties into the aorta. This shunted portion traveling through the foramen ovale has the highest oxygen levels and directly perfuses the brain and the heart via the carotid arteries and coronary arteries respectively. Fetal deoxygenated blood returning from the SVC and lower extremities is directed towards the right ventricle and pulmonary trunk. The majority of this blood flows past through the ductus arteriosus into the descending aorta and perfuses lower extremities and hypogastric arteries. Deoxygenated fetal blood returns to the placenta via two umbilical arteries. Thus, three special shunts, the ductus venosus, foramen ovale, and ductus arteriosus, allows the most oxygenated blood to perfuse the heart and the brain.